look at this later for any reason. Okay, so we got that going. All right, so same thing as normal, what we did last semester. So thank you guys for coming out for this. So I've got the Kahoot thing. I'll start it in just a second. Hopefully this thing doesn't get in the way over here. So between each question, if we need to go over anything, I went ahead and put some stuff together just on a PowerPoint like this, so we can do that as we go. I mean, you guys can come on the mic, it's perfectly fine, or you can just kind of do everything in the chat, it's perfectly fine with me. Hopefully, nothing happens with the internet connection, so we move and there's some issues with it. I've got a LAN connection, so it's a direct connection, so hopefully that works better than the Wi-Fi. But if we happen to get thrown off or anything for any reason, I will immediately post something on Facebook, try to get it started again. Things on my arms? Zach, what are you talking about there? Oh, yeah. I thought I'd dress up just a little bit for this. So it's also, since we moved, it's not as humid here. Nowhere near as humid. Yeah. So it's not as bad. Where we were before, the the humidity was terrible, and it's non-existent here, so it actually feels a lot cooler. So, okay. And if you guys see anybody that needs to be admitted or something, and I'm not seeing it, just let me know. All right, so we're gonna go ahead and get started with this. Just so you guys know, between interventions 1 and 2, it just kind of alternates. I try to give it a random order just so if we don't finish it for whatever reason, we at least see some of both subjects. So we'll go ahead and get started with this. And in order to improve shoulder adduction, the humerus must be mobilized in what direction? Yeah, so that one I put 60 seconds on, so I apologize for the ominous music. I never do 60 seconds, usually 30 or 20. But I thought these questions were a little bit tougher, so I just put a little extra time. They're not all 60 seconds. Most of them are like 20 or 30 or something. So in order to improve shoulder adduction, the humerus must be mobilized in which direction? So adduction, so basically when you start off like this and then bring it back to the midline, hopefully you don't know that by now. But when I'm thinking about this, I like to come up with a strategy. And so I kind of came up with some stuff here. I mean, it's more or less what Dr. Yu went over, but just to kind of give a framework for how I like to answer the question. So the first thing I do, regardless of what the movement is you determine the more mobile component, and then you move on to what either the static or less mobile component. So we're at the shoulder joint. So we've got the more mobile component being the humerus, and then the static or less mobile would be the glenoid fossa. And then you identify those. And you do need to know, obviously, which one's convex, which one's concave. And so you've got the shoulder moving, or the humerus moving about the shoulder joint. So you've got your convex humerus moving on a concave glenoid. And that's just because convex, it's bulging out, head of the humerus. Concave, you've got the glenoid cavity or glenoid fossa. And so remember that when you've got convex moving on concave, you've got a situation there where where the slide and the roll are going to be in opposite directions. And so then that kind of takes you to step 2. Then you got to determine the directions of the roll and the slide. And this thing down here, I came up with kind of an order that you can do things. And depending on how the question's asked, you can either go one direction on this or the other. So in this kind of question where they straight up give you the movement, so shoulder adduction, and they ask you which direction to mobilize it, you can kind of use this framework right here on the top. So you can start with the specific movement, which is, you know what it is, it's shoulder adduction. And then you can from there figure out the direction of the roll. And what seemed to work for me is with the roll, you consider the mobile component, and whatever direction the mobile component moves when you're doing that movement, that seems to be the direction of the roll. So when I do adduction, it appears my humerus is moving inferiorly. And so that tells you that the roll would be inferior in adduction. And then you can use that, whether it's the opposite or in some cases the same, to figure out what the slide is. So you go from roll to either opposite or the same. In this case, it's the opposite because it's convex moving on concave. And then that tells you the slide would have to be superior. And the kind of the things that I saw based on the assignment and the key that he posted is that when you're looking at the roll is in the same direction as the mobile bone moves. So if you're doing adduction, the humerus is moving down, so the roll is inferior. If you had it the opposite with abduction, humerus is moving up, so the roll would be superior. And then the slide is always in the same direction, seems to be the same direction as the mobilization. So if you can figure out that the slide is superior, then that tells you the mobilization is superior. And so I can kind of just go along this framework right here from the specific movement to the mobilization, and for me, it worked every single time. And so for adduction, you'd have to mobilize the humerus superiorly. Does that framework kind of make sense for everybody? If not, I got one more question exactly like this on the next question, number 2. Does that make sense to anyone? Any questions on that? That's what made sense to me, is kind of just going through this. And actually did get a chance to do it on the second question, so cool. All right, so if that didn't make sense, we'll go ahead and switch to the next one. Same thing, same wording of the question, but different movement. So in order to improve closed chain ankle dorsiflexion, the blank must be mobilized in the blank direction. Yeah, so this one you would mobilize the tibia and do it in the anterior direction. So so you can go back to this one and do kind of the same thing. And remember that when you've got these questions, particularly I think mostly with ones that involve the lower extremities, you do have to worry about if it's closed chain or open chain. So here's kind of more or less what you see with the closed chain ankle dorsiflexion. Again, you're decreasing that angle between the dorsal part of the foot and the front part of the leg. But remember, when you're in open chain, that would be if you actually lifted your leg off the ground, so to speak, and then pointed your toes up toward your head. But when you got closed chain, you're planted on the ground. And so really your entire foot, including the talus, is the static component. And then the tibia is rotating over a fixed talus. So for example, if the guy started out with his tibia perpendicular to the ground, going into this closed chain dorsiflexion, he'd be moving it into the direction that you see it right here. So just remember that. But you can do the same thing, same wording of the question. They give you a movement, and then it says, how would you mobilize it? And in this case, you mobilize the tibia, because in step 1, you determine the mobile component and then also the static component. So the tibia is clearly more mobile here because it can go from all the way perpendicular to rotating out in front here anteriorly. And then the static component would be the talus. And then you just have to figure out, is it a concave tibia or convex? And the tibia, remember, it has that tibial plafond. Remember that from lab. He pointed it out in the first lab exam that we had in, where we actually had immersion, but it was concave. And then the talus kind of sits in there, and the tibia can rotate over the fixed talus. And so in this case, you've got a concave tibia moving on a convex talus. And so in this case, it's the reverse of what we saw in the previous question. Now we've got concave moving on convex. So now that tells us they're in the same direction. So, you know, you can get into all this here, but the basic idea down here on the bottom left is we've got a specific movement. We know it's dorsiflexion, and we know that the mobile bone is going to be moving in the same direction as the roll. So when you're doing dorsiflexion, your tibia is going anteriorly. So the roll would be anterior. We just said it was the same. The roll and the slide will be the same because it's concave on convex. So if the roll is anterior, the slide is anterior, and then the mobilization is in the same direction as the slide, so that would also be anterior. So the full answer to that question would be you're mobilizing the tibia in the anterior direction. So, and I went through all of the practice questions that he put up, and it works for all of them. So hopefully that makes sense. Does everybody get that? Tried to make some like a kind of a scheme out of it, so that way you can just follow the same thing every time, and it works pretty well. It's easy for me to understand. Yeah. And the nice thing is with this is if the question was worded in a different way, which it's not the next question, but it's like number 5 or something. If it's worded such that like I think he did this in 1 week in the sync session. He put a picture of himself moving a particular limb. So from there, you have to determine what the movement is. You can just go the reverse direction. So you can see what direction he's mobilizing the patient. And then from there, you can go to the slide, and then to the roll, and then to the specific movement. So glad that works out for everybody. So let's go on to the next question. Some of these other ones are not near as involved, so should be able to get through them a lot more quickly. Okay, what's the treatment for a patient presenting with low back pain, muscle pain, and swelling redness in the area? Yeah, so this one, cryotherapy, so it's ice or cold therapy, definitely going to be this one. So I guess that the main thing to understand here is that when you've got pain, you can really treat the pain with a number of modalities, really either hot or cold. But one of the other, it was like those 3 things that he wanted us to know, 3 considerations. The top one was, first of all, does the treatment even work for that particular issue? And then the second thing was basically, can you kill 2 birds with 1 stone? So can you use one treatment to address 2 things? And so that's kind of what we got here. We've got pain could be addressed really with cold or heat. But in this case, you've got swelling, redness, which those were 2 of the cardinal inflammation signs. So this person has some inflammation. And so it wouldn't make sense to use thermotherapy or heat therapy on this. It would have to be something that's cold to address that inflammation. And with these 2, the reason you'd probably want to use a cold pack is because when you've got the lower back, first of all, the ice pack will stay on there pretty well. It's not like you're trying to put it on an irregular surface. But also with the cold pack, it can cover a much larger area. And then with the icy massage, not only does the practitioner have to be there moving that ice, or just ice literally, but also it takes a lot longer because this is usually only good for a smaller area of the body. And it could probably be assumed that the lower back, it's probably a much larger area. And so for that reason, the cold pack would be better there. Anyone want to dispute that or any comments there? think the main thing is that if this were switched and instead it was something about increasing range of motion or addressing stiffness, then you would probably switch to either of these down here. And if you're still on the lower back, you wouldn't use the paraffin treatment because it'd be practically impossible to get your lower back in the paraffin bowl. You'd have to use the hot pack also with that. So icy massage, pretty much small areas because it can be time consuming if it's a larger area. And then with paraffin, I think it was pretty much just like the hands and the feet, really just the distal extremities, not the low back. So number 4, couple answers. Sharp localized low back pain with stiffness. Which of the following is false? I think this one actually just has one answer. Sorry, I don't know why it said that. I apologize for that one. I don't know why I just read it right off this. For some reason, it said it had multiple answers. This one only had one answer, so I apologize for that. But we've got sharp localized low back pain with stiffness. And so this is asking which statement about that's false. So when you've got this one right here, so the pain is mediated by type A delta fibers. So I think when you've got that really sharp, when it's localized pain, that's your type A delta fibers. And I may have included something on that somewhere. Yeah, it's for a different question. But remember, these you've got short duration, sharp, stabbing. I don't think it's listed here, but these tended to be more localized. Whereas C afferent fibers, these were the ones that were can be more diffuse. They're achy, dull, throbbing, and so on and so forth. And then if you've got A delta fibers, those type are not, they're opioid insensitive, or they're not sensitive to opioids. So, I mean, we wouldn't obviously want to use opioids, and we wouldn't even be prescribing those. But A delta would not be opioid sensitive. Only the C afferent ones out of those two were opioid sensitive. And then with these two, the person has pain and then also stiffness. So that differs from that previous question. So if you got the stiffness, the heat's going to be better to address both the pain and the stiffness. Because remember, the heat's going to be that thing that kind of loosens all the underlying connective tissue and so forth. And so also it can increase the muscle extensibility, and that also helps to, and also loosen up the connective tissue in the joint, and then increases the range of motion to address that stiffness. And then as for this one, again, kind of the same thing. You're not going to be able to stick your back in the fluidotherapy chamber. That's really, again, just for the extremities. And so the hot pack would be superior. And so, yeah, that actually makes sense. Zach commented down here. I don't know if you guys can see that, but when you're doing the paraffin, apparently you can also do, I guess, just really anything that's small enough of a region or convenient to put in the paraffin bowls. But apparently he's seen the elbow done for that. Hey, Zach, do you think you could do the knee for that? Knee's a little bit bigger than the elbow. I don't know. I don't think he really went over that. But what about the knee along those same lines? Brush method. Yeah, that's true. Yeah. Okay, cool, guys. Okay, so let's go to the next one. Okay, what osteokinematic movement is Dr. Yu looking to restore in this picture? Yeah, cool. So this was the one that I said you could pretty much use that reverse, the reverse of the first two questions that we did. So yeah, this one, see, did it? Oh, I guess, did you guys see that? We got it right, so clearly that showed the picture. I guess I didn't even notice that. I wasn't even looking at it. Okay, so on this one, here's the same picture right here. I just got this straight out of his, I think it was a sync session. So he's applying, so the person is lying in the prone position. So he's applying a force on the leg, and it's going from posterior to anterior. So we can just say that it's in the anterior direction. And this question right here is the reverse, because instead of giving you the movement and saying, how do you mobilize it, it's showing you the mobilization and then asking you about the movement. So that means we can go the opposite direction on this little flow chart right there. So he's pushing posterior to anterior, or just anterior. We still need to figure out what the bones are that are being manipulated here. So it's at the hip joint. And then we've got the femur pretty much, and then the acetabulum of the pelvis. And so the femur is convex because it has the large femoral head, and it's going to be moving about the concave acetabulum. So large cavity, kind of like the situation with the shoulder joint. So you've got convex moving about or moving on concave. So that tells us we're dealing with an opposite situation. So before we went from specific movement to roll to determining opposite and same, and then to slide, and then to the mobilization. Well, now we're going to go from mobilization, the direction of that, to the slide. So just exactly the reverse. Well, he's mobilizing in the anterior direction. So you could say posterior to anterior, or just anterior. So the slide is in the direction of the mobilization. So the slide would be anterior. We've already determined that the slide and the roll are opposite. So if the slide is anterior, the roll is posterior. And then which movement do you have when you basically move your hip posteriorly? It would be hip extension, where you're basically moving your thigh behind an imaginary coronal or frontal plane. So it would be hip extension. So does that make sense to everybody? You kind of do the same thing, except you pretty much just go in the reverse direction. But I always felt this was a pretty decent method. You guys have any questions on that, or are you guys good? I think most everybody got the answer to that question. All good. Cool. Cool. Okay, so let's move on. I think that was the last 60-second one. So it should go a little bit faster from here. Number 6. Which of the following graded mobilizations is good for targeting pain rather than stiffness? This one is 2 answers. Yeah, so it's the red one, basically red one and the yellow one. So we've got low amplitude. Well, first of all, so this was in I think the manual therapy lecture for interventions 1. So he talked about basically 5 grades of mobilizations. Really the first 4, I guess, were the ones that they were non-thrust ones. They weren't thrust, they were just talking about the amplitude, and then whether they were at the beginning of the range or if you're pushing against the resistance. Or the barrier. And so he had a table, it was actually this one right here. You start out, basically the first 2 are both beginning range. You're not pushing into the end of the range or against the barrier yet at that point. So they're both beginning of the range. So that's the major way I would think about this question. So you could pretty much rule out these 2, green and blue. So 1 and 2, grades 1 and 2, beginning of range. Grades 3 and 4, engaging the barrier, or end of range would be the same thing. And then it kind of just goes as you go from 1 to 4, low, high, high, low, like a plateau almost, for whatever reason. So low, high, high, low. And then the first 2 are beginning of range, last 2 are engaging the barrier. If the question was reversed and it was talking about stiffness instead of pain, then you'd be talking about these two over here. So you'd be talking about engaging the barrier. And you'd have this one, the blue one, high amplitude engaging barrier, that would be grade 3, whereas low amplitude engaging barrier would be 4. So I'm guessing he's gonna have something on this, like this on the test, and guarantee these ones in some form or fashion are gonna be on the test. So I would make sure I know those, because there's no way he would have posted that review if those were not important in some form or fashion. So, okay, let's go to number 7. In the patient response model, an increase in active range of motion from 45 in session number 5 to 60 degrees in session number 6 is what? Yeah, so objective asterisk between sessions. So on this one, pretty much if you're looking at, so if it's anything that the patient themselves is reporting, so basically anything without an objective measurement, you've got subjective. If it's something that the PT is measuring, so you'd have to measure range of motion. You'd have to, and I assume with the Faber, they're probably also measuring range of motion there, flexion, abduction, external rotation. That would be objective. And so this one is active range of motion, so it's objective. And going from session number 5 to session number 6, that's just a 1 session change, but it is the next session, at least in order. So that would be a between session change. As I understood it, and I don't know if there's an exact cutoff. I don't know if he would do this. Dr. Yu didn't seem like the type. Maybe Dr. P, but not Dr. Yu. I just got the sense across sections or sessions would be that it would have to go more than 1 session pass. So like if it was session 5 to session 7, maybe that would be across sessions. Does anybody, did he actually go over if there's an exact cutoff for that? 3 to 4 is what he said. Okay. Well, this one is, yeah. Okay. Weeks. Yeah. So this one is just 1 session. So that would definitely be most likely between sessions there. Again, if this had been instead about pain, so they're reporting, pain of 3 out of 5 went down to 1 out of 5, 3 out of 10 down to 1 out of 10 or something, then you'd be looking at subjective asterisk. But again, 5 to 6 would still be between sessions. So, and just remember, because I feel like this could probably be something that he asks about, but when you got that comparable sign, that's when you are, the example he gave was you were doing something with the back, doing some movement, whether it's a twist or a bending, and then it produces a symptom in the legs, the pain in the legs. So that the leg pain would be an example of a comparable sign. He went over that pretty good in one of the sync sessions, so I'm guessing that's probably a good sign. It's going to be on there in some form or fashion. So, okay, let's go to number 8. Which of the following joint mobilization rhythms is best for treating joint stiffness? Yeah, definitely. So, so this one was actually just the staccato. If you go to, let's see, yeah, I actually had it right here, I guess. So when you're looking at the staccato type rhythm, that's what you see for just stiff joints. So I guess grades 3 and 4 mobilizations, which that's characteristic of the type you would use for stiff joints. That's the staccato type rhythm for the mobilization. And just knowing that you're speeding into the range quicker than you're bringing it back to the original position. The slow, smooth rhythmic, would stationary hold also be appropriate for that? Yeah, probably. Did I even have that as an answer? No, I didn't have that one as an answer. Yeah, so I agree with that. I agree with that. Because for stationary hold, it says stretching a stiff joint. So you could definitely do that one also for stiffness. In terms of the answers, it would have just like that were given here, just staccato type. And I put that in there just because from what I've noticed on a lot of the questions he's asked, that is Dr. Yu, it's different than Dr. P. For Dr. P's questions where he had like an all of the above or A and B or something, I feel like he leaned towards the all of the above almost every time, if memory serves. Whereas Dr. Yu, it's kind of a 50-50. He had a lot of those questions kind of just pure, throughout the sessions, and he posted the answer key to the ones we didn't get to. And there were a few in there, and I don't remember a single one of them. Maybe one was like an all of the above. He likes to throw these kind in there. And then, so I would just say when you're looking at those, don't just assume it's the all of the above or some combination of them. But yeah, I would say, I didn't think about that, but yeah, I would say staccato type definitely. But if it had said staccato type and stationary hold, I would have said that too. So that's probably why we got a lot of stationary holds there. Anyway, yeah, I think let's see, what is it? Yeah, he mentions distraction. Yeah, distraction answers. I thought when you said distraction, I thought you meant literally like the technique distraction, not like a red herring. Yeah. So yeah, yeah. So yeah, definitely. Yeah, both of these, I guess, in this case could be the answer, but not the slow, smooth, rhythmic. That's really just for the for grades 1 and 2, which are associated with pain. Yeah. All right. So next one, number 9. Does this one actually have? Yeah. Which of the following would be considered a lateral to a push-up? Has 2 answers. Yeah, yeah. So this one, 2 answers right here. And with the laterals, I think the sense I got is just something that's similar, probably works the same muscle groups, or at least same muscle groups, and maybe provides like a slight extra challenge or something like that, whether it's coordination. He had a picture in, just got this right out. I don't know if this was for push-ups specifically, but this person right here, she's doing push-ups or variations of them, where she's either doing it on some kind of a balance board or she's holding a dumbbell in the other hand or something like that. That's just the sense I got there. So, when you're doing a push-up, it's pretty much the same thing as a bench press, except that instead of being with your belly over the ground, it would be on your back. He mentioned those being for closed chain scapular movements. So, Zach, would you disagree with the bench press on that? Consider the bench press is a little more, more open chain. Okay. So I guess with this, consider just the closed chain. So if that's what we're going to go with, then the balance board push-ups would be the best answer there. But in terms of these over here, these don't deal with the same type of movement or muscles. Obviously, this is abdominals. These are triceps. So instead of pectorals. Okay. I could probably shoot him an email after this and just clear that up about that. Yeah, tell you what, I'll send him an email after this, unless someone else wants to do it, and we'll clear that up about that. So I'll send him an email. But I guess the point of laterals is just something to increase the variation, so that the person doesn't get too bored with it or they don't get too accustomed to it. Yeah, I could definitely see that, unless you were doing a fairly light amount of weight with that. Because you could, with a bench press, I mean, you could do a small bar on that. Not necessarily like doing like 200 pounds or something, but you could do a small amount. But in any case, I'll ask him about that after this, what he's going to say, and then I'll send a message out for that. Okay, and also I think lateral, was that an actual term or was that just something that he came up with? I swear he said that that was just a term he had. It wasn't like an official thing.
Yeah,
Still looking on the test.
I'm pretty sure he said he made up that term. I think his idea is just that it's something that's like on the same level versus like
Yeah,
progression if they're not
okay,
ready to progress. I think
yeah.
that's what he means by it.
And I guess when I was thinking about this in my mind, I wasn't thinking like a 1 rep max, but I was just thinking like, just like maybe a bar or something just by itself. And then there's different ones that you can like, the ones that already have the weights on the side, like 30 pounds, 40 pounds, 50 pounds, like you can do that kind of stuff. But I'll ask him specifically about open chain versus closed chain. So yeah, that actually makes sense. Yeah. So Zach's saying instead of progression or regression, laterals, and it's basically staying the same level, more or less same intensity. Yeah. Okay. But I'll ask him specifically about open and closed chain. So, all right, next one, number 10. Which type of nerves transmit non-painful sensation related to vibration, stretching, and mechanical pressure? Yeah, so A beta. So with these, remember you can bust these up into a couple different groups. The top two here, A delta, C afferent, those were the pain sensitive ones. A delta was sharp, more or less sharp pain, myelinated. C afferent, unmyelinated, slow pain, more the dull kind. And probably also when you're going back and look at these, remember that you've got to look at the percentages, the conduction velocity, all that stuff. Just an aside, but remember A delta is like 20% of pain fibers. C afferent's more 80%. C afferent's opioid sensitive. A delta is not opioid sensitive, stuff like that. And then these bottom two were not for pain. A alpha was proprioception. And then A beta was this stuff up here. So you've got the vibration, stretching, mechanical pressure, really just a bunch of stuff that appears to be mechanoreceptor in origin. Whereas these top two are the pain ones, A alpha, A beta, non-pain or not pain. A beta was mechanical stuff up here. So, and so make sure you go look at that. But also remember that generally when you see A implies that it's a myelinated axon because you got three types of fibers. You got A, B, and C. And so A are usually the largest and they're usually myelinated. C are normally the smallest and they're usually unmyelinated or myelinated to a really small extent. And B is somewhere in the middle. So anyway, we can go on to the next one. Patients working to improve coordination and proprioception would be delivered what kind of intervention? So this is just kind of general, the terminology. Neuromuscular reeducation, right. So really, I guess, and there were some definitions he put in there. Let me see if I actually put those here somewhere. I may not have. That's okay. But just generally speaking, when he was talking about these kind, if you're doing anything really with, I guess, any kind of movement, quality, proprioception, balance, coordination, you're under the realm of neuromuscular reeducation. And he had a list of stuff that was on there. And then he had a question on his, probably the sync session, I think, yeah, where he was talking about manual therapy versus therapeutic exercise. I think the big distinction between those two is that when you got therapeutic exercise is really anything where there's any kind of resistance or strength, where strength or anything like that's the focus of the exercise. And it doesn't have to be necessarily going on the weights and the machines and doing that kind of, weights, but just anything where there's resistance is more therapeutic exercise. Whereas manual therapy, you don't actually have that. Do you think he's gonna, I mean, I guess it is open book, so you could write this stuff down. But do you think he'd be wanting those codes? Like the, I forget exactly what the codes are called, but you know, where you're probably not, yeah, CPT codes, yeah, that's right. Yeah, I don't, and also just while we're on here, on that topic, um, what does he mean exactly with it being like with having notes? Um, like, are we talking like handwritten, like either typed or handwritten notes from ourselves, or are like or does he mean you can actually have open um, the class PowerPoints? Anything, Alex? Whatever you want. Nice. You just have to show it. Okay. As long as you bring it to your computer, it's good. Okay, cool. That is a relief because I was thinking about going back and like just putting all the PowerPoints like on a sheet of paper. So okay, that's actually good to do. Okay. Thank you guys. Next question, number 12. What is the ideal temperature range in degrees Celsius to achieve maximal results in increasing tissue extensibility and range of motion? I don't think that's advisable. Yeah, so he talked about this in his sync session. So when you're talking about just tissue extensibility, you know, the range of motion improvements, you're looking at 40 to 45 degrees. I don't know this, but I think if you're in this range, 35 to 40, you're not getting any benefits. First of all, because 37, remember 37 degrees Celsius is body temperature. So if you're just putting something on you that's in this range, it's probably doing no good whatsoever. And then also remember to know the, I guess the body temperature ranges. You're looking at 35 to 38 degrees Celsius would be the range. Oh, and you know what might be a good idea? Someone mentioned low blows, but I don't trust it for anybody in the program. What you might do is copy down. I mean, it's probably in the PowerPoints, but make sure you know where the formulas are to interconvert between Fahrenheit and Celsius, because I don't have those memorized off the top of my head. So I would have to look those up. And I don't know if there's ever a case where we learned something in Celsius and they asked for it in Fahrenheit or something, or the reverse. But I would definitely know where those conversions are. 9/5, is that from Celsius to Fahrenheit or the other way? He just said memorize the temperatures given. Yeah, that's probably fair. I feel like he's probably pretty true to his word, though. Not that he can't, not that he can't expect anything of us, but he's probably pretty truthful to what he says. Yeah, okay, so thanks. This is Celsius to Fahrenheit right there. And when you start getting up to these higher temperatures, you start running the risk of, you know, you can start decreasing enzyme activity. Because I mean, if you get it hot enough like this range, you increase the metabolism in that area. But you start going to higher temperatures, you're going to start losing enzyme activity because you're getting to the above their temperature optimum. So the enzymes won't work as well. Metabolism actually will drop. And then if you get hot enough, then you'll actually potentially kill the cells there. And I don't know if that can actually cause a burn. It probably does, but essentially you're killing the cells if you put the temperature too high. So again, make sure you know that range right there. But then also if you're below that, you're not getting any therapy because you're basically at body temperature. Yeah, we are the only ones who do that. So number 13, for ultrasound on the anterior thigh, so basically right in the middle of the quads, and superior shoulder regions, which parameter would probably change, assuming you're at the same depth and assuming the treatment you're doing is the same? Yeah, so this one right here. So looking at these, you got the duty cycle. So that pretty much is, and he said don't worry about 50%. So it's really just 100% or 20% for ultrasound. So if you're looking at 20%, that's pulsed. It's 80% off, more or less, I guess 20% on. I don't know if it's exactly that, but basically you're not having the machine on long enough to actually heat up the tissues that it's contacting. So in that case, you're really just looking at mechanical effects there. Whereas 100%, you get both mechanical and thermal effects. So with 100% duty cycle, you're heating up. But see, with this, we're basically keeping everything the same. It's the same treatment. It's just a different location. So in this case, we just assume keep it at 100% for thermal effects. The frequency you change if there's a difference in depth that you're going to. So I said at the same depth. But just remember, when you're looking at this, if you're doing a lower frequency can penetrate through to deeper tissues. So the lower frequency being 1 megahertz. And then if you're at 3 megahertz, that can get to, or that only goes to the superficial tissues, even though it's a higher frequency. And for 3 megahertz, you're looking at 1 to 2 centimeters, whereas 1 megahertz can go all the way to about 5 centimeters. So basically 1 to 5. But since we're at the same depth, we wouldn't need to change the frequency. And I don't know if this is like clinically applicable, but I'm just saying based on the question, the concepts. BNR, that was something specified by the instrument. And in any case, remember that the lower the BNR is, the better. So you'd actually be going to a worse BNR here because 3 to 1 is lower than 5 to 1. 5 to 1's higher, so that wouldn't actually be as good. And the reason I was thinking about this was he talked about different parts of the body, like different tissues, I should say, heat up at different rates based on their attenuation coefficient. So on the top of that list, you have bone, cartilage, and so those are going to heat up a lot faster than the muscle. And so if you're in the anterior thigh, you're pretty much just really hitting quadriceps, really just muscle in that area. There's not much else. Versus on the superior shoulder, you've got the acromion of the scapula. I mean, you can even feel that. So if you're talking about the superior shoulder where you're going to be hitting bone with that ultrasound, you'd probably want to take the intensity down a little bit. Whereas at something that you're only hitting muscle, you could probably get by just having a higher intensity, relatively speaking. But when you're in the area of bone or cartilage or something like that, you'd probably want to drop the intensity. And he had a nice flow chart somewhere. That's not it. Where did I had something where I used it later, maybe. Did I not include that? I may not have included that. But he had that chart where he talked about how you go between, or if you got a thermal effects that you're desiring versus just purely mechanical, you look at the depth and all that. I don't, for some reason, I didn't transfer that into the PowerPoint, but I'll do that before I post it. But does anyone want to dispute this as to why you'd want to drop the intensity of the ultrasound, or does it kind of make sense to everybody? Cool. Yeah, and the key here is same depth, so you wouldn't be changing the frequency. But if you were, say, going for a deeper muscle versus the quadriceps, then you might want to change the frequency, where the deeper one's going to be get 1 megahertz and the superficial one 3 megahertz. All right, cool. Next question, number 14. For superior supraspinatus, about 3 centimeters deep, what's the best setting for ultrasound if the goal is reducing stiffness? There's only one answer, so I don't know why it says 2. Yeah. So on this one, there's 2 that you can pretty much rule out right away. And that's because the goal is reducing stiffness. So really when you got the stiffness, you're looking at something that's you're gonna need heat. So, I mean, you could use, hot pack or something, but those may only target superficial tissues. So if you're looking at reducing stiffness, it's gotta heat up. So you're looking at thermal effects rather than just purely non-mechanical. And so for that reason, the 20% duty cycles are out because those would be purely mechanical. Oh, 3 centimeters, yeah. So 100 centimeters or 100% duty cycle, that would be thermal effects. So you'd be able to heat up the tissues that way. And then between these two, you're looking at 3 centimeters deep. Suppose that's just the depth of the tissue. So it's a little bit deeper, so you could use a lower frequency setting. If you did 3 megahertz, that one only went down like 1 or 2 centimeters. So 3 centimeters is out of that range. So you'd have to use a lower frequency setting to actually penetrate that deep. So 1 megahertz. And then in terms of the 0.5, kind of the same reason as the last question for the intensity. If you're in that superior supraspinatus region, you've got the acromion in there. Depending on how deep you're going, you also have, cartilage in there. The glenoid fossa and humerus are both coated with articular cartilage. I don't know that it would go that deep, but certainly the acromial process is in that area, and you'd have to worry about that. And out of those attenuation coefficients, bone was the highest. He had a question in his sync session about that, which one had the highest attenuation, or I think it was actually worded which one would heat up the most. But bone wasn't an answer. Had it been an answer, it would have been the highest one. I think after that, it was like cartilage or something. So anyway, let's go to the next one, number 15. For which of the following therapies is malignancy the primary absolute contraindication? Yeah, so ultrasound, I'm not exactly sure why. I mean, my guess would be is that I don't know if the ultrasound, because most tumors are a little bit deeper. They can be superficial, but if you're going for a deeper type of modality, the ultrasound may be able to get to them. And I don't know if the waves somehow stimulate the tumors. I'm not sure exactly, but it did say that. These other two, I think really the primary contraindication, absolutely, for thermo and cryotherapy is really just the impaired mentation and impaired sensation. And so, because if they can't tell you that they're burning or they're getting frostbite or something, cool. Thanks, Megan. Yeah. So if you can't tell, if they can't tell if they're burning or freezing, or if they're, I think with cryotherapy, one of the additional ones is if young and older individuals, because younger people may not have receptors that are as sensitive yet. And so you can have damage even if they don't feel anything. And with older individuals, geriatrics, they may not have the sensation anymore. They lost it as they aged. And so really with both of these, mentation and sensation and ultrasound is the malignancy. And Megan commented here that, yeah, if the ultrasound reaches the tumor, it can stimulate the growth of the tumor. And we don't want that. So,
hey, can I hop on for a sec?
Yeah, sure.
I just wanted to mention, I remember very specifically in the for the thermotherapy, that was the one that specifically said mentation was an absolute, and in the cryotherapy, it was only a precaution. I thought that was kind of unusual. I think it's just because of like the burn possibility.
Yeah.
Regain blood flow, but I mean, of course, there's all those other special conditions for the cold that was absolute. But I just wanted to throw that out there.
Thanks, Jeremiah. Yeah. I guess that actually is correct. And also along those same lines with the heating, I mean, you had to put 6 to 10 layers around the hot pack, whereas for cryotherapy, you only need a pillowcase basically, or something like that. So it seems there the thermotherapy is a lot more severe. Yeah, so thanks on that. Thermotherapy, Yeah. And were there any absolute contraindications for cryotherapy? I might have just misread that. Were there any absolute ones for that? Like 5 weird ones? Yeah, so like I think it was like the hemoglobinuria, yeah, that stuff. Okay, yeah. Okay, cool on that. But yeah, malignancy, ultrasound therapy, definitely want to avoid that. So let's go and look at next one, number 16. Which of the following is not a general effect of cryotherapy? Yeah, so this one right here is a hallmark of inflammation. And really the cryotherapy dampens that because you have, first of all, it decreases the metabolic response, the rate of it. And so you have a drop in the metabolism. So if there were any, basophils, mast cells, anything like that in the area, they're not going to be releasing the histamine and prostaglandins as much anyway because their metabolic rates dropped because of the cold. So this is actually what you would see more or less if you had added heat, thermotherapy. Cryotherapy actually inhibits this. And he actually had a decent couple things right here. So on the left here, increased temperature, this would be the thermotherapy, which directly stimulates inflammation. But then when you have a lower temperature, cryotherapy, you get inhibition of the histamine and prostaglandin release. So it inhibits that inflammation. Everything else here is characteristic of the cold. So you have decreased nerve conduction velocity, whereas with heat, it increases it. And also in the general effects of the cryotherapy, he also had, one of the uses of it was for spasticity. And with spasticity, you got muscles, contracting aberrantly. But muscles can't contract without nerves. So I think with the spasticity, by decreasing the nerve conduction velocity, that also helps to eliminate the spastic muscle contraction. So those two things kind of go together. And then you've got local vasoconstriction. Remember that heat dilates and also cold constricts, CC, cold constricts. And then with this one, this is just a fancy way of putting edema. Not that heat necessarily causes edema, so I made sure to put potential. So on the flip side, with cryotherapy, you have decreased potential for edema or decreased potential for fluid movement from the blood into the interstitium. And really when I don't know if he would get into this too much, but if you were talking about heat causing increased edema or potential for edema, remember the heat's causing dilation in that area, local dilation. And so if you dilate blood vessels, you're allowing more blood to get into the area. And if you got more blood in the vessels going through the capillaries, you have greater blood pressure going through those capillaries, and more blood pressure on the arterial side of them, you have more filtration. And that filtration out from the blood into the interstitium, if it's not returned to the venous side, then you've got edema. So because cryotherapy constricts the vessels, you have less blood going to those particular capillaries, so less chance for filtration, less chance for edema. Was there a time for how long it took vasodilation to occur? I don't remember a time. I mean, generally with the cold therapies, you were looking at anywhere between, depending on the effects you were looking for, like 5 to 20 minutes. Does anyone know if he had an actual time it took for the vasodilation to start? I don't remember there being one. There wasn't an async. Okay. I'll have to look back at that. I don't remember the exact number. He gave times, I know, for like 10 to 15 minutes. Okay, 10 to 15. I know he gave a bunch of times for how long it took to, that you would do a particular treatment, like cold pack, 10 to 20, or about 20 minutes, and then the ice massage, or not the ice massage. Well, yeah, I think it was the ice massage. depends on if you're looking for muscle facilitation or if you're just looking to reduce pain or something like that. It's in the 8 superficial cold. Okay, so 10 to 15 minutes. So apparently 10 to 15 minutes to see the effects of the vasodilation. There's that. Yeah, does that have anything to do with the, hey Evie, does that have anything to do with the, where when you put it in cold, you get, the muscles actually get stronger first, and then it kind of reverses, and then the opposite's also true with heat. When you put heat on the muscles, they get weaker, but then it kind of goes, they get weaker first, and then they get stronger. Does that have anything else to do with that, or is that a different concept? Different concept, okay. What do you guys think? Do you think Dr. Adams, because this is his stuff, do you think Dr. Adams is going to be the easier content on the test, or Dr. Yu? I'm thinking Dr. Adams is probably going to be a little bit easier questions, but I don't know. What do you guys think on that? Yeah, I agree, Casey. And I don't see Dr. Adams asking as much on like the little numbers kind of stuff. I feel like heard from the last class that both of them were the hardest. Gate was pretty bad, yeah. He's more overall picture. Okay. Okay, well, let's go on and see if we can finish this. 17, which of the following has the greatest attenuation coefficient? Oh, man. Yeah, so so bone has the highest one. Yeah, that's not good. The first, so the T1, not T2. Oh, man. Is that the quiz or the exam, though? But anyway, while you're dealing with that, exams, okay. So yeah, he had this picture in here. I don't think, you know, obviously know everything, all the numbers on here. But I mean, I would probably know a general idea of the progression for these. Bone, highest attenuation coefficient, which is why, you know, if you're applying heat or something in this area, if there's a bone directly in that area, you'd probably want to dial back the intensity just because that bone's going to heat up a lot faster. Apparently nerve apparently doesn't heat up at all. And it goes bone, cartilage, tendon, and then muscle. And then fats at the bottom. But I would probably know the bone, cartilage, tendon, muscle, and then just know pretty much all the other stuff other than blood vessels are below that. But I don't think we need to worry about all the numbers. I guess in any case, with this one, bone has the highest attenuation coefficient, so it heats up the fastest. In this list, this one, adipose tissue or fat, that would be the lowest rate of heating if you're doing ultrasound. Because remember, the attenuation coefficient is specific for ultrasound. Oh, man. Yeah, and Jeremiah brought up a good point. Yeah, so when you're looking at the attenuation coefficients, it's all about the collagen content. So the greater the density of collagen per unit in the tissue, the greater the attenuation coefficient. Because remember what that is. When you get the waves that are going on the tissue, they can do one of three things, or they can do three things, not just one. They can either refract the sound waves. And remember, refraction is just whenever you've got the waves going in and they change medium. So like they go from, I don't know, skin to bone or something. It diverts the angle of the incident radiation or whatever it is, the sound waves. And then they can also be reflected and then also absorbed. And so it's that absorbance that's increased by having more collagen. And then at the very bottom, well, not at the bottom, but close to it, the fat really doesn't have much collagen in it at all. It's mostly just triglycerides. And so it's going to have a much lower attenuation coefficient because of that. Bone has a lot of collagen in it. That's what gives us its tensile strength. So it's all the way up at 96%. So anyway, attenuation, I think, involves absorption. So attenuation coefficient accounts for all three of those things, absorption, reflection, and refraction. But I'm pretty sure that the higher the absorption is, so 50% absorption, but in any case, the higher the absorption is, the higher the attenuation coefficient. I don't think the other two actually increase it. I think they may actually decrease the attenuation coefficient because they're not contributing to the absorption of the sound waves in order to heat up the substance. So when the sound waves are absorbed, that's what causes it to heat up. So the more absorption you have, the higher that attenuation coefficient. I think that's how it works. But in any case, yeah. So 50% of it is at least accounted for by absorption. But with bone, you've got a lot of that. So next one, where are we? I'd probably just say with that, knowing the relative order. What is the primary effect that is shared between thermotherapy and cryotherapy? Yeah, so increase in pain threshold. So the other ones are really just characteristic of one or the other. So, you know, like decrease in histamine and prostaglandin release. That one's just cryotherapy. Thermotherapy, other way, it's going up. Increase in inflammation, that's thermotherapy. Cryotherapy, it's dropping inflammation, which is why you use it for heat if the tissue's hot or swelling. And then the increase in blood viscosity, that's really just for cryotherapy. And actually that brings up one of the points based on somewhere back here in the chat. So we were talking about the contraindications for cryotherapy, and you've got those things like hemoglobinuria, all those weird names. I think a lot of those have to do with situations where you have high plasma proteins. There's a lot of protein in the blood, and if you cool down the blood and there's more protein in it, more density of protein, it tends to make the blood more viscous than it would if you just had normal concentrations in the blood there. And so in general, cryotherapy increases that viscosity, but if you have way too much protein in there, it'll cause it to become even more viscous and potentially dangerous, which puts work on the heart. But both of them increase that pain threshold. And so that's why in those questions where you're talking about the pain, and then there's also either swelling or increasing range of motion, no one speaks of, yeah. Well, we're past that class, so, which is very good. But anyway, that's why both of them treat pain, but you have to default to the other thing, whether it's increasing the range of motion or treating the range of motion, or I'm just blanking on what I just said. Or if it's hot, or if it's redness or swelling, that's how you choose between thermotherapy and then the cryotherapy. So yeah, we're all glad to be done with that mess. Okay, number 19. Shoulder extension occurs in the blank plane and around the blank axis. Yes. So with this, again, do I have two of the same? Do I? Huh. Is that the same? So sagittal plane, and then, oh yeah, okay. Yeah, okay. Anyway, so yeah, when you're looking at this, I don't know if if anyone has trouble with this, just one thing can kind of help with learning the plane that it's moving in. Someone once told me this, that if you imagine the air, you could paint it with a paintbrush, which is a ridiculous thought. But if you basically imagine whatever limb you're moving, cover it in paint, and then you move it in whatever plane that you're painting, if you could see that paint sticking on the air, that's the plane that you're moving that particular limb in. So when you do extension, you're basically just bringing it back down like this. So you've got sagittal plane. And then the coronal axis is the axis that pierces through the sagittal plane. So if you're looking at sagittal plane, you've got either frontal or coronal axis. But remember, it's also a medial-lateral axis because it goes, if it pierces the sagittal plane, it goes from the lateral to the medial, back to lateral as it goes through it. And then just remember, you also have a frontal or coronal plane, but then that axis that goes through that is the antero-posterior axis. That makes sense to me because if you've got a frontal plane, the only axis that can go right through it is going from anterior to posterior. So that's the way I think about that. So that's why this one was the answer, number 13. Guaranteed there's going to be one of those on the test. Number 20, there is greater hip extension passive range of motion when the knee is straight compared to bent to 90 degrees. Why? Yeah, this one was pretty much straight out of, this was straight out of his, there were some questions he put. We didn't get to this one, but if you haven't done so, I'd recommend doing it, going looking at the questions that he posted, and he put answers up to them, so you don't have to worry about that. But you've got elimination of passive insufficiency. I tried to come up with another kind of way to think about this. Let's see, this one was, yeah, we'll do the hip one. Got two examples here. The way I was thinking about this, because I always try to come up with like a, just a way to conceptualize it like a flow chart. And so I came up with, you first identify and name the movement. So, when you're doing this, it's exactly what he had in the pictures. You got hip extension, that's what we've got here. So that's the movement. And when you talk about hip extension, you can either talk about agonists or you can talk about antagonists. So if we've got agonists of the movement, there's really two major ones that I can think of. One, you've got hamstrings, and two, you've got gluteus maximus. Although in this case, the hamstrings are going to be what are the subject because they're the ones that are two joint muscles. And so pretty much the question is just describing exactly what we did in the sync session. So the guy is able to generate more force when he's in the straight leg versus when he bends the knee. And so if you're talking about an agonist, something that's doing that movement, well, when he bends the knee, the hamstrings are shortened, basically. And so if the hamstrings are shortened, they're put on slack. And so because it's an agonist that's the cause, I guess you could say, of that, it'd be an active insufficiency. So basically when he bends the knee like this, or flexes the knee, you have the hamstrings get shortened. And so they're not able to generate as much tension or force because they're already shortened or put on slack just from being shortened across two joints. So if you've got an agonist, that's really more or less the cause. I think of that as being the active insufficiency. When you've got the antagonist, so the movement's hip extension, but the antagonistic movement would be hip flexion. Well, you do have a muscle that spans two joints. That's a hip flexor. That's rectus femoris. Remember, rectus femoris, even though it's a quad, it's also a hip flexor because it goes from the pelvis, the AIIS, down to the tibia. And so if you've got the antagonist limiting force production due to its limited, like the finite length of its tendons, then you've got you've got a passive insufficiency. So he's moving in this case, when he's got his knee bent like this, when you bend your knee, that's a quad stretch. So the quads are being stretched in that case. Quads are being stretched already when his knee is bent. Well, the rectus femoris would also be stretched, and its tendons only have a certain finite limit to how much they can stretch. So when he starts doing the hip extension, rectus femoris is already stretched, or even if it's passive, which is what this question was, the PT's moving his leg into hip extension, but if his knee's bent and already stretching the antagonist, rectus femoris tendons, it's going to limit that movement. And so then you've got passive insufficiency. I don't know, this is the way I thought about this kind of thing. I don't know if that helps anybody, but he stressed this one pretty good in the sync sessions. So I'm guessing there's going to be something on this, considering he had a question very similar to this. I actually got it from his in his answer key. So anyone want to discuss this anymore, or does it make sense to everybody? Cool, yeah. And I don't know that it actually has much to do with whether or not it's passive range of motion or active. I don't know that it has much to do with that, because regardless of whether at least on this part, regardless of whether or not he's doing it actively or the PT is actually moving it into hip extension, either way, the way I'm seeing it, the rectus femoris is still limiting, because the rectus femoris is stretched either way. Because regardless of whether or not he's flexing the knee himself and moving the hip upward, or if he's having it moved for him, you're still stretching that rectus femoris tendon, and it would still be limiting in my mind. So I don't know that the passive range of motion or active actually has anything to do with this part of it. And also, when it came to the wrist thing that we did, Dr. Adams had us do, we were actively making the fist either way. And we could do that for passive or active insufficiency, depending on whether the elbow is flexed or straightened out. So I don't know if it has anything to do with passive or active range of motion. Does anyone want to clarify that? Yeah, so when you're doing active range of motion, yeah, the hamstrings they're definitely put on slack, and so they're not able to contract as much. And so you'd be forcing it more into the gluteus maximus. Think of it as muscle lengths, yeah. Yeah, so in this case, hamstrings are insufficient because they're too short, because they're put on slack. In the case of the rectus femoris, or the hip flexor, it's lengthened too much, so the tendons have kind of reached their limit on that one. So, okay, let's go to the next one, number 21. Which of the following is not characteristic of the closed packed joint position? Yeah, so on this one, when the joints are close packed, close together, so the way I kind of think about it is I think about, for me, the femur relative to the tibia and the knee joint. So joint capsule volume or intra-articular volume is minimal. That's where you have maximal joint congruency. In the closed pack, ligaments are taut. But when you're in closed packed, that's where you have static efficiency being better. Open packed would be where the dynamic safety is efficient. So that's why this one was the answer. So which one not for closed pack? Okay, next one. Which of the following factors increase internal torque produced by a muscle? Yeah, so this is the one he said that he guaranteed would be on the test. Remember that there's several ways you can increase the torque produced by the muscle. The first one being just the muscle makes more force. More force equals more torque. If you increase the length of the moment arm, so if you increase how far the muscle is, how far it's applying the force away from the axis of rotation, which is the moment arm, that also increases the torque. And remember that the general formula is force times moment arm. So either an increase in either one of those will increase the torque. And then also, because you've got the trig in there, if you have the force perpendicular to the axis of rotation, that's going to increase the torque as well. So 90 degrees is what will be maximal. Any less than that, so 80, 70, 60, whatever it may be, you're not getting the maximum amount of torque. So all three of those are what would increase the torque. Okay. Most of these other ones are fairly straightforward, so we'll probably try to shoot through them pretty quick. Movement shown below is considered gravity either facilitated, resisted, or minimized. Yeah, so facilitated. Because all he's doing is just bending forward and basically just using gravity, almost like you think of just stretching. Just doing a stretch, so you touch your toes, stretch the hamstrings. All he's doing is just letting gravity take him forward. So gravity's facilitating that. Gravity minimized would be kind of like if you had somebody who, like we did it with manual muscle testing in lab, where if you had a situation where the person couldn't, I guess they couldn't do shoulder abduction against resistance and gravity, you put them on their side, and then they just did it in a gravity minimized position. I think he could have either one, Casey, in terms of the movements or the pictures. I'd be prepared for both, honestly. I feel like for this one, this type would be a good one for a picture, but Dr. Yu, I feel like, is pretty thorough. And I feel like if he did it with words, it would be more than enough detail to figure it out, though, with him. He seems pretty thorough with his stuff. All right. Next one, number 24. Which of the following is false regarding exonomesis? Yeah, so that's the one that's false. So when you're looking at these, I think I had a picture in here. Yeah, so you've got NAN. So you've got neuropraxia, exonomesis, and neurotmesis. And really, I guess the major as you go from left to right, they're getting more and more severe. With exonomesis, you don't have the entire nerve severed. And you can kind of see it in this picture if you look. The nerve itself hasn't been severed. You can see the walls of it are still intact right here. But some of the insides of it, maybe the axons within the nerve, got severed. Because remember, a nerve itself is a ton of neurons. And so the nerve itself is intact, the borders of it, but some of the axons within it might have actually gotten severed. So that's what you've got with exonomesis. Neurotmesis would be, you can see the gap right here. Yeah, the perineurium is intact with internal damage. Yeah, so with what he's referring to is, remember that the nerve itself has different layers. You've got the perineurium, you've got there is, I think, a mesoneurium and an endoneurium. And the perineurium is surrounding the entire nerve, if I remember correctly. It's the external border. Or is that the epineurium? I'm actually second guessing myself. But in any case, with this condition, you have axons within the boundaries of the nerve that have been severed, but the nerve as a whole is still intact. Neurotmesis, the external border of the nerve has been completely severed. So this is much more severe. And then with neuropraxia, you can see the axon itself is completely still intact. And that just results from, if you hit it, like hit your funny bone, or if there's just a short amount of compression. But with axonotmesis, you have to have prolonged compression that could potentially cause infarcted tissue, which just means that the axons are destroyed. Not the whole nerve, though, in that case. And then because the axon is damaged, you do have demyelination in that case. So that's why this one was the answer. This would be neurotmesis if it were the entire nerve being severed. Okay, number 25. Which of the following is true when performing a resisted calf raise as shown below? So on this one, okay, so there's induced and then reactionary torques. Hope I had this right. If I remember right, induced torques, that was the torque that's due to gravity. So when you're looking at a movement, like he had someone holding a dumbbell up, abducted to the side. The induced torque would be whatever gravity would tend to make it want to do. So if you're holding a dumbbell up to the side, gravity would tend to make the dumbbell want to fall back, which would be adduction or adduction. And then reactionary torque is whatever the muscle's actually doing to counteract gravity. Do I have that right, guys? Just want to make sure before we go any further, but I'm pretty sure I got that right out of the PowerPoint. Yeah, okay. So when you're looking at this picture, let's see, I thought I included it. I guess I did not. Oh well, I'll have to do that, put that in later. But anyways, when you're lifting your calves, you're doing a calf raise, and you're supporting all that weight on your back, gravity is tending to want to make you go down, which if you can look at your foot, but as you go back down, that would actually be a dorsiflexion. So the induced torque at the ankle joint, I'm pretty sure, is a dorsiflexion, whereas the reactionary torque of basically what you're doing to resist gravity, what the muscles are doing in the calf raise, that's the plantar flexion, the reactionary torque. And when you're doing the calf raise, so doing the plantar flexion, in that case, the gastrocsoleus, they're actually contracting concentrically. Because as you're going from neutral to pushing up off with your toes, basically, they're actually doing it concentrically because they're shortening to push you upward. And that's why this one was the correct answer, because in order to do that, instead of flattening forward or falling back, your back muscles, the deep back muscles, have to stabilize everything and basically hold your torso upright. And so they'd be contracting isometrically just to hold you in that position. Does that make sense to everybody? All right, cool. All right, next one, number 26. Which of the following displays the correct order of force generation of muscle contractions? Yeah, so this was something he hit pretty good also. Yeah, eccentric, the strongest, isometric in the middle, and then concentric are going to be able to lift the least. So make sure you know this order. Won't linger there too much, just so we can get through as many of these as we can. But he made a point of going over this specifically in the sync session. So I think that's probably a good chance it's going to be on the exam, considering it's 50 whole questions. So number 27, which of the following is false regarding muscle contractions? Yeah, so that's the, yeah, this is the false one. So on this, a lot of concepts here. One of the ones we went over quite a bit. I remember someone answered this in a sync session. Muscles strongest at their mid-range length. So somewhere between fully lengthened and fully shortened, that's where they're strongest. That was another factor also when he had the typical biomechanics problem where you've got the elbow flex at 90 degrees versus down here versus up there. Another reason, other than the fact that you've got it perpendicular at 90 degrees, another reason that it's strongest there is because it's at the mid-range length. The second one here, that's the force velocity curve, remember that? So when you're dealing with concentric contractions generally, as you load it up with more weight, you contract slower. And to me, it's pretty intuitive. I mean, if you just like try to bicep curl a 5-pound weight versus 10 versus 20, as you get heavier and heavier, it's slower and slower because that's the concentric. Versus eccentric, it's faster with an increased load. So if you clearly pick up something that you can't really lift, it's going to drop much faster than actually if you have a really light load. So they're opposites of one another. Eccentric, faster with increased load. Concentric, slower with increased load. So that's your force velocity curve right there. And then with motor unit recruitment, just remember that type 1 recruited first, and then you've got type A, or 2A, excuse me, 2B, 2X, so on and so forth. But remember, the reason it does that is for energy conservation. So if you don't need a lot of strength, or I should say force, to lift something, there's no sense in recruiting all of the muscle fibers. You're just going to recruit the ones that will get the job done. But if you have to start lifting more weight, so you have to apply more force, you'll recruit the type 1s, but then you may need to add some on top of that, maybe some 2A or something like that. And then if you're recruiting if you have to lift a lot of weight and give a lot of force, then you might need to recruit all of them. But if you're only lifting a little amount of weight, like a soda can or something, there's no sense in recruiting 2X or even 2A. So it's all about what he said, energy conservation. And then with this one, this is kind of I thought it was kind of interesting when we learned about this. But when you've got active and passive tension is just the contraction of the muscle. So the muscle contracts, that's active tension. The passive tension, the way I like to think about it is if you, like when you stretch a muscle, so you stretch a muscle and everything associated with the muscle stretches also. You've got the membrane of the muscle, the sarcolemma stretches, some of the proteins in it like titin stretch, the tendon stretches, and it's like stretching a rubber band. So when you stretch a rubber band, you can feel the tendency for it to snap right back into its original position. So you've got some tension there in the rubber band that's passive because it's not the muscle itself contracting, but it's tension nonetheless that's provided by stretching all the other associated structures. And so then when you, if you stretch the muscle and then contract it, you're summing together the active tension, so the contraction of the muscle, plus the recoil of all of those other structures, the recoil of the tendon, the recoil of the muscle membrane, all that stuff, the passive tension is being added onto the active tension, so that way you can get more force. And so I didn't really mention it, but just like if it makes sense to anybody, when we did plyometrics back last semester at Health and Fitness Promotion, you stretched the muscle before you did the eccentric contraction before the concentric. And the logic behind that is if you eccentrically contract the muscle, you're stretching those things that provide passive tension. You're stretching the sarcolemma, you're stretching the tendon, you're stretching all that stuff. So that way when you do the concentric contraction, it's the muscle force plus the elastic recoil, that passive tension of all the other stuff, and you get more force than if you just had the simple concentric contraction by itself. And so the passive tension gives you more of that. But the active tension is not tendons or it's not sarcolemma, it's just the muscle itself, normal muscle contraction. And if you want to think about it this way from the heart, PTSD, but Frank Starling mechanism where you stretch the walls of the heart with increased EDV and you get a bigger stroke volume. It's the same concept there. Passive and active tension being added together. Okay. Makes sense to everybody? All right, cool. Next one, 28. With constant load, which of the following is more likely to result in a ruptured ligament? Yeah, this one, again, this was right out of, I think we actually got to this one in the sync session. And yeah, same here, Casey. And if I remember right, when you're dealing with ligaments, as you start to make them more taut, they get stronger. You start to unwind that collagen a little bit, and they start to get that tensile strength. So when you actually lengthen them reasonably, they get stronger. I think rapid loading, I think everyone put an answer with rapid loading. I mean, that's just, if you just set something on something, it's gonna hold intact better than if you just throw it down really hard. If you load it really fast, it's gonna have issues holding up to that load. But if it's shortened, it's not as strong in the shortened position. You actually have to lengthen it a little bit for it to get that tensile strength going, so to speak. So I think in his question, I think it was longer and shorter, I think is what it was. I think it was longer. If you look back, I think it was longer and shorter on that one. I think I put lengthened and shortened in this one. How so? Hey, Chris, you want to come on real quick? How so?
Yeah, I'm just thinking that so he was saying just because it was shorter, the stress strain curve, when it's longer, you have more, the percentage, the proportion's different. So when it's longer, it would last more. Because he was saying in the manual muscle test, at the end range, that's when you would have a rupture of a tendon or a ligament, So I was thinking shortened would be I guess you wouldn't shorten a ligament, it would just be short. If that makes sense.
Oh, yeah. Okay, I get what you're saying. I guess when I wrote that, I guess I could have put short and lengthened. Would have probably been better. Do you agree with that?
Yeah, because a smaller ligament
really
would rupture.
Yeah. I guess with this one, you could either have lengthened and then short would probably have been a better terminology there. So, is that good with you, Chris?
Yeah, that's good.
Yeah, okay. All right, let's keep going. Number 29. When are the plantar flexors most likely able to generate greatest force upon the calcaneus? Yeah, so again, eccentric contraction is stronger than the others. And then the other part of this was that it was midway between plantar flexion and dorsiflexion. So it's in the mid-range of the length of the plantar flexor muscles. The other ones could be ruled out in this case just because they don't say eccentric. And remember, eccentric was stronger than isometric, which was then stronger than concentric. So eccentric is the strongest there. But again, they're also strongest at the midpoint of their length. So 30. Which of the following is most likely to result from tensile loading of a peripheral nerve? This is also from his stuff. Yeah. So when you remember that neurons or nerves in general are not really that good at resisting tension, they can they can slide, they can do excursions throughout the canals of the body and all that. And you can compress them to some extent, but they're really bad at resisting tension. The nerves, that is. And so if you do put tension on the nerve, it results in a decreased cross-sectional area. And then that kind of, the way I think about it is when you do stretch it, it doesn't give that much. So the part that you stretch, it kind of gets a little bit narrower because it's not stretching out. So the only thing, if you pull on it, it just has to kind of decrease its circumference, which decreases the volume inside the nerve. And then you have less space for all the contents in there. And so the pressure inside it, the intraneural pressure, goes up. He had a slide where it really just came directly off of that. Easy to miss, but it's in there. So decreased cross-sectional area and then increased intraneural pressure. Okay, 31. Which of the following is not a component of the acute phase of peripheral nerve recovery? Yeah, so motor retraining. So in the acute phase, um, when you have a peripheral nerve damage, I think more or less what you're trying to do is really just keep the injury from getting worse, manage the symptoms a lot at first, before you start getting into retraining certain things that you might have lost. If you had a nerve like damage to the axillary nerve or something like that, you'd probably have a lot of issues with shoulder abduction. So you probably wouldn't be retraining a lot of movements in the acute phase. You're just worried about basic things like immobilization. They can do that with the splint or the brace. He had a slide on that. And then maybe basic movement, but not really so much motor training where you're kind of relearning movements. And then really all of this stuff, if you were in the chronic phase, you'd really have none of these. Really with the chronic phase, that's where you have, like, it's so damaged that you pretty much are not really going to have hopes of recovery. And that might be more associated with the neurotmesis, the most severe, where you actually have a complete laceration or something of the nerve. Then you're more worried about compensatory movements, being able to work around the damage and the deficits that you might actually have from that. But with acute, and then the phase that comes after that, I think with those, you're more or less hoping that you can regain the movement. But with acute specifically, it's just basic stuff. You're worried about making sure it doesn't get worse, and not really so much the neuromuscular retraining at that point. Basic movement, just initial immobilization, maybe getting it, a little bit of basic movement there, a little bit of strength back, and then splinting and bracing with the acute. And he said, he actually said at the end of, I think it was the last sync session, would have been yesterday, he put up a slide that had this little table. It looks like he made it on Excel. And he said, make sure that for the different injuries, so whether it's neuropraxia, axonic mesis, neurotmesis, kind of know some general features about them, like I don't remember exactly what was in there, but it was more or less like what stage would you be in, or what's the prognosis, or what kind of things would you do. He has like 3 slides. If you oh gosh, when I post some stuff here, I can actually, he didn't send it out, it was actually in the sync session, but I took a snapshot of it. I can actually just put that in the Facebook thing when I post this. But it just had some stuff in here about those 3 nerve injuries: neuropraxia, axonic mesis, and neurotmesis, where he just asked some basic questions about them, like what would you do in each case, and like it probably involves a lot of this stuff right here. And then in the PowerPoints and the asyncs, he had 3 slides, I think, where he just listed a bunch of stuff that you would do. So Okay. Next one, 32. Forward bending of the spine and neck with unilateral dorsiflexion does what to the nervous system? So basically this. Yeah, so this one was a tensor. So he had, I think it was tensors and sliders, and oh, I must have deleted too many slides or something like that when I went back and did this. But anyway, when you're looking at this movement, so remember the Dr. Adams, I think, was talking about it, that the nervous system from the brain, really the brainstem, all the way down to all the peripheral nerves, they're just really one interconnected system, and so they can move back and forth. I remember from anatomy, I think it was semester 1 when we talked about basic neurodynamics, like when you flex your neck forward, you're actually kind of pulling the spinal cord up a little bit superiorly. And when you do cervical extension, you allow the spinal cord to kind of go down into the vertebral canal. So you can kind of, more or less tug it in and out of the vertebral canal. And so in that picture, I don't have it up, but when he was doing cervical flexion, he's actually pulling the spinal cord superiorly through the vertebral canal. And I think when you do the dorsiflexion, which is what he was doing with he was outstretching the leg, so he's stretching the leg out like that, and then doing the dorsiflexion, in the lower extremity, with the dorsiflexion, he's kind of pulling the nervous system, let's say, toward the foot. So he's pulling it caudally. So on one end, it's being pulled up. On the other end, it's being pulled down. So you've got a tension there. If it were a case, and there's some pictures in there where in one case it's being moved up, and in the other case it's also moving up, then you've got a slider, which would be excursion, if that were the question. But in that case, whenever he's cervical flexion, leg outstretched, and then dorsiflexion, bringing the toes toward the head, and when he had us do that, I don't know if you tried it, but it's pretty uncomfortable. That's because you're putting tension on the nervous system, like the brainstem, spinal cord, and all the peripheral nerves. So that one was a tensor. And I don't know, I doubt he's going to throw any curveballs on this. He'll probably just use some of the examples that he did in class. I would think so. Oh, no problem. But I think I would at least know the ones that he mentioned in class. So, okay, next one, almost done, 33. Which of the following is incorrectly matched? Let's see, so this one, I think yes, I had the picture here. So let's see on this one. So incorrectly matched. So let's see, let's can zoom in here a little bit. Okay, so one right here, that's that toe region on this. So with the toe region, this one is true. So more or less there, you just kind of have a bunch of protein fibers like collagen. They're initially kind of crumpled up, almost like this, so to speak. And initially when you're loading it, they kind of stretch out, and eventually they'll get to being linear, so to speak. So you'll stretch them out. Not really stretch them, but uncrumple them. So they'll go to like a zigzag curve to just being a straight line would be how I would think about it. And then once they're at a straight line, that's when you begin stage 2, which is where then you start stretching them out like that. And so in stage 2 right there, I guess in this general region right here, you've got the elastic part. And so when you're stretching in the elastic part, yeah, you have the linear increase as you deform it, or as you put more load on, you deform it and stretch it. But in this range, when you stretch it, it'll go back to its original baseline length. So you're not causing any kind of irreversible damage there. So 2 would be more or less elastic. And then little region 3, it's pretty small in this picture, but that would be the plastic region. So you stretch it basically to 0.5 right here, and it's going back to its original size, but then you get past that yield point and you start getting into a state where you're stretching it so much that you're starting to cause maybe some micro tears in it. Maybe not super dangerous at that point, but the point where when you release it, it's not going to go back perfectly because you've caused some damage there. And then eventually you'll get to a fail point, which would be 6, where that's pretty much rupture. Like you've pretty much gone through the plastic component and you've given it all it's got, and then it just tears. So initially you can stretch it, it'll go back to its original size, no irreversible damage. You get into zone 3, and then you can start getting that micro damage to where it won't go back completely to its original shape or size or whatnot. But then you get to 0.6, and that's just ultimate fail point, and you get a complete rupture of that. So in this one, 1 is the toe region. That's where you're uncrumpling those fibers, so they're kind of zigzagged, and you can kind of pull them, right? It's kind of like a noodle, like if you're eating spaghetti or something. It's curled up on your plate, and you can kind of straighten it out, right? And then stage 2 there is the elastic zone. I didn't have anything on that. And then number 3 was wrong. Let me make sure that tendon is stretched with 100% capacity to return to its base structure or base length. So when you're in zone 3, you've already caused micro damages here because you're in the plastic region. So it's already reached its limit of elasticity at this point right here. And so now you're causing micro damages, and it won't be able to, it's going to retain those damages even once you release it, basically. But at 0.5 right here, you haven't yet actually caused the complete rupture of the structure. That's not until you get to 0.6. So 0.5 is that yield point where you cross from elastic to plastic, and you start causing micro damages. But then at 0.6, basically the tendon or whatever it is just ruptures, like an ACL tear. That's a ligament, but same kind of thing. Does that make sense to everybody? And I probably could have worded this a little bit better on some of the choices, but like number 5, the limit of 100% elastic recoil, this would be the limit of it. So once you get past 5, it's not going to be perfect elastic recoil. I thought that he said, someone asked that, and I thought that it could be applied to both of them. I thought that it could be applied to both of them. Does anyone want to comment on that also, to Taylor's question? Thought it was both of them. Yeah, I think someone asked about that, and he said both, yeah. So tendons and ligaments, because they're both made of the same kind of, they're both made of dense regular connective tissue, so they're very similar in structure, so yeah. Okay, next one, just a couple more. Which of the following are incorrectly matched? This one's a easier one than the last one. Yeah, so this one, paraffin heat, convection. The reason this one is not correctly matched is because when you're putting, like let's say you're doing the hands in the paraffin, if you're submerging them, one of the techniques you can actually, there's 2 techniques that they talked about, but one of them, you submerge your hands in there after you get the wax on there. But basically, you have to keep the hands static. You can't move them around. And so because the paraffin is not moving, and your hands are not moving, you just have 2 substances in contact with one another, and so there's not one moving past the other. If you were in a whirlpool, maybe, you could call that convection because the water would be moving around the limb or whatever it is that you've got submerged. But this one would be more or less conduction, because you don't actually have the fluid or whatever it is actually moving around the hand or the foot. And then vapocoolants, that's the only one that was evaporation. That was the only one. And then infrared lamp radiation, just because it's a lamp, you've got light waves that are actually traveling through space to the skin. And then ultrasound is conversion, because you've got the conversion of an AC current, so it's electrical energy, or excuse me, that's before. You basically have mechanical energy that's converted to heat. So remember that the mechanical energy is created from the AC current. And I don't know if you would ask that, but this one's not open book. So remember that when the machine converts it converts the AC, basically electrical current, to mechanical energy. Remember, that's reverse piezoelectric effect. I don't know if he would be mean, but if he had two choices where it's piezoelectric effect and reverse piezoelectric, it's the reverse one. Because the reverse one is going from some kind of electrical current to mechanical energy. But then the conversion part is from mechanical energy to heat. Because with conversion, you're talking about heat transfer. So to be heat transfer, it has to be that part of the conversion, mechanical energy to heat. The other one, the reverse piezoelectric effect, doesn't have to do with heat. That's conversion of electricity to mechanical energy. The actual conversion is mechanical energy to heat, because conversion is heat transfer. Yeah, it would be kind of mean to do that, but from what some other people way up here said, I don't know that that's out of the realm. So I'd at least be prepared for it. So, and then just remember conduction, which wasn't on there. That's where you have the two substances, neither's moving, they're just in direct contact. So the best examples of that would probably be paraffin, and then also just a cold pack or cold pack or a hot pack. Okay, one more. A patient has a cut on their arm. Which of the following would be false? And it's at 2 days since the cut. Yeah, so this one is, so with this one, so 2 days since the cut, this one was mostly about the time periods of the three phases of healing. So you've got inflammation, proliferation, and maturation. So inflammation was 0 days, basically to 6 days, I think. Proliferative is 3 to 20, and then maturation's 9 and on. And again, with that, notice there's a lot of overlap there. And then when you're talking about 2 days, according to those ranges that he gave, proliferation wouldn't have even started yet. So it would have to be in the inflammatory phase. So that's why this one's not right. With inflammation, you have mast cell, basophil, histamine release, you have that. And the collagen synthesis doesn't start until proliferative phase. And in the proliferative phase, you have type 3 collagen. He did mention that. I don't know how much detail he's going to get into on the test with that. And then in the maturation phase, the type 3 collagen is replaced with type 1. And then this one, assuming there was dull pain, that one would be more or less the C afferent fibers. Because remember, if it was sharp pain, that would be the A delta. And right at the onset of the injury, like when he initially cut himself, that probably would have been A delta fibers, and it would have been a sharper pain. But given that it says dull pain, I think he used that somewhere. Where did I have that? Longer duration, dull throbbing pain for the C afferents. So if it was dull, it'd be C afferent. And it's been 2 days since that, so he might still have some dull pain there. But the sharp pain probably would be gone. That would be more acute pain right when he had the injury. Okay, any questions there? Okay, guys, that's all the questions I've got here. So yeah, thanks, Jeremiah. Thank you so much. And thank you, thanks everybody who came out for this. I'm going to So that's finished there. That might actually be the first time. That might be the first time that we actually got through every single question. We normally don't do that. But so thanks everybody. I'm gonna see about getting this uploaded, and then I'll post it on Facebook. I'll post any slides that I put on there. Thanks guys, and I will see you guys next week. I'm probably next week gonna do something over, I'll look and see what exams we've got, but in the future, probably musculoskeletal and neuroscience. We'll probably do something with that. Yeah, good luck to everybody on the tests tomorrow. Make sure tonight, if you guys need to update your computers, update the software, update it tonight. And then also make sure to restart the computer and all that. So I'm gonna go ahead and get off of here, and I will say good luck to everybody. Thanks for coming out for this.